The second half of this evening, I'm going to talk about occupational lung disorders and pulmonary vascular disorders. Occupational lung disorders are all so-called interstitial lung disorders or restrictive lung disorders. Occupational lung disorders or interstitial lung disorders are caused by disease that damage the interstitial or connective tissue of the lung. This restricts the ability of the lungs to expand and fill with air. Interstitial lung disorders include a large group of diseases with different causes, but with the same or similar clinical and pathological changes. The damage to the interstitial tissues is due to chronic, non-malignant, non-infectious diseases of the lower respiratory tract. There are approximately 80 different types of interstitial lung disorders. We will concentrate on the pneumoconicosis group of diseases. That would be silicosis, asbestosis, and black lung disease. These are interstitial or occupational lung diseases that are caused by inhaling inorganic dust and particles. There is another type of lung disorder or occupational lung disorder known as hypersensitivity pneumonitis. This is an allergic response to inhaling organic dust. So to recap, there are two types of occupational lung disorders. There's pneumoconicosis, that's in organic dust and particles are inhaled, or there's hypersensitivity pneumonitis, which is an allergic response to organic dust. People at risk for hypersensitivity pneumoconitis, people at risk for hypersensitivity to pneumonitis. People at risk for hypersensitivity pneumonitis are people such as cotton pickers, farmers, people exposed to moldy sugar cane, and people who work with birds. During this lecture, we will concentrate on pneumoconiosis disorders. The severity of the disease depends on the size of the inhaled particle, where it settles in the respiratory tract, and the general health of the individual. What happens with occupational lung disorders, they're caused by exposure to noxious substances. An inhaled noxious particle is deposited in the lungs and an inflammatory reaction occurs. Over a period of time, the disorder develops. This means a fibrous inflammation forms with a chronic induration or hardening. In other words, a scarred mass forms in the lungs. As the worker continues to breathe in the dust, more and more areas arise of scar tissue within the lung. The inhaled substances lead to an inflammation, which damage the interstitial tissue and the alveoli. The scarring causes the lungs to lose their elasticity, and the lungs become stiff and non-compliant. So it's, in other words, the lungs are stiff and it's difficult to inflate them. The gas exchange is impaired and it leads to hypoxemia. The signs and symptoms. Although the inhaled noxious dust particles vary, the signs and symptoms are basically the same, be the diagnosis black lung disease or asbestosis. So, the onset can be gradual or abrupt. The person will have a dry chronic cough. They'll have DOE, D-O-E, that's dyspnea on exertion. Probably this is the first symptom to arise. Later in the course of the disease, the person will have dyspnea while at rest as well. They'll have rapid, shallow respirations. Fine inspiratory crackles can be auscultated at the lung bases due to the decreased airflow, and the fingers will be clubbed. There will be clubbing of the fingers and toes due to hypoxemia, and there'll be black streaked sputum. That's especially noticeable in black lung disease, which was where it gets its name. The complications are pulmonary hemorrhage, respiratory failure, and cardiac failure. First of all, let me just give you a little background on black lung disease. Black lung disease is caused by long-term exposure to coal dust. Initially, the body is able to deal with the problem, and macrophages take care of it. With prolonged exposure to the coal dust, the airway literally becomes clogged with coal dust and macrophages. These things that were taking care of it now begin to clog the airway. So the coal dust mixed with the white blood cells or macrophages that are trying to destroy it clog the airway. This greatly compromises the gas exchange, resulting in localized emphysema in the affected area. And as the disease progresses, the emphysema becomes generalized. The scarring, the pneumoconiosis spots become black lesions, and that's actually what can be seen. There's approximately 400 deaths a year attributed to black lung disease. Silicosis is caused by the inhalation of silica dust. Many occupations are exposed to silica dust. Hard rock miners, sandblasters, pottery workers, granite cutters, and silver and gold miners. Nodules form and conglomerate in the lungs. Emphysema develops as it does with black lung disease. Probably about 200 deaths per year occur because of silicosis. Asbestosis. Asbestosis is the inhalation of asbestos dust. Asbestos is a naturally occurring substance that has been used for thousands of years. It's been used as far back as 4,500 years ago. It became increasingly popular in the late 1890s because of its resistance to heat and electricity and its flame retardant properties. So it was used to insulate homes and heating systems and pipes everywhere. It was noted for retaining heat in the winter and keeping heat out in the summer. So we found it in asbestos shingles, asbestos wrapped around pipes, asbestos in electrical devices, and on and on and on. In the late 1980s, the use of asbestos was banned in the United States. An estimated 1.3 million workers in construction and industry face asbestos exposure. About 400 to 500 deaths per year occur because of asbestos. Asbestos exposure can lead to a rare form of lung cancer known as mesothelioma, which is often the cause of death. So when I say how many people a year die from these diseases, that doesn't account for the millions of people affected with the diseases, because the deaths only happen after a long and arduous course of battling these horrible diseases. Asbestos has been banned in the United States since 1980, and thank God. However, you still find it in some of the older homes, and when it isn't going to be a problem until it's disturbed, and that's when the little dust particles fly into the air. So anybody removing asbestos or working around asbestos has to wear hazmat type equipment or that type of personal protective equipment, because it can be very, very dangerous and deadly. The interdisciplinary care and nursing care, the diagnosis is mainly based on the signs and symptoms and the patient's occupation. But pulmonary function tests are going to show restricted respiration. The vital signs in O2 sats will be greatly compromised. The ABGs will reflect hypoxemia and hypercapnia. There'll be low O2 sats, I already said that. The O2 sats and hypoxemia worsen with exercise. Chest x-ray is going to show interstitial damage, scarring, and lesions. A bronchoscopy may be done to obtain tissue for biopsy, and a lung scan can show the extent of the scarring. The big thing here is prevention. Prevention is key. Personal protective equipment must be worn to limit the amount of inhaled particles. PPE involves special masks, gloves, and outerwear. And if you've ever seen anybody removing asbestos, they look like they're going to the moon, because it looks like they have spacesuits on. But OSHA requires PPE to protect workers exposed to occupational lung diseases, and this has reduced the number of people affected. And OSHA was introduced in the 1980s, somewhere in the middle of it. The maintenance and treatment of occupational lung disorders, the first thing you have to do is identify and remove the cause. Inflammation and progression can be slowed somewhat by using anti-inflammatory treatment. The general treatment, though, is supportive, sort of, and very similar to the treatment of COPD. There is no cure. Stop smoking. Oxygen treatment is needed. Improve nutrition. The person should consume small, frequent meals with supplements. Avoid infection. Stay away from crowds, things like that. Emotional support. These people need a lot of emotional support. It's very, very anxiety-provoking when you can't breathe. And medications like bronchodilators and anti-inflammatory meds. For the nursing care is pretty much exactly like COPD, if you want to go back and review that. They're going to have an effective breathing pattern, inadequate fluid intake, inadequate nutrition. They're going to have activity intolerance, and there's going to be caregiver strain. Ineffective coping occurs. Often occupational lung diseases begin to show symptoms 20 to 30 years after the person was exposed initially to the noxious inhalants. People who began their careers at 18 to 20 years old may have to switch careers or become disabled in their 40s. This causes financial and emotional strain. It affects all members of the family, and the family members may suddenly need to assume the role of caregiver for their breadwinner. The patient may face a career change leading to lower income or unemployment. The primary focus with occupational lung diseases is teaching. Teach people who are at risk how to reduce the risk. PPE, good hygiene, that includes hand washing, showering, and washing their hair. Teach people to avoid other lung irritants like smoking and air pollutants. You can refer them to smoking cessation groups. There are medications that can be used, such as a patch or Chantix. Suggest the influenza, pneumonia, and COVID vaccines. Suggest yearly TB testing. teach the importance of adequate fluid intake, teach proper coughing and deep breathing techniques, and teach about the use and effects of medication, including oxygen. Next, I'm going to talk about pulmonary vascular disorders. Pulmonary vascular disorders affect the blood flow to the lungs. Because the cardiovascular system and the respiratory system work in harmony with each other, any condition that affects the blood flow to the lungs will also affect the blood flow to the heart. First thing is a pulmonary embolism, abbreviated PE. A pulmonary embolism is a blockage in a pulmonary artery. The most common cause of an embolism, as you know, is a blood clot or a thromboemboli, but it can be caused by other things like tumors, bone marrow fat, foreign matter, etc. For the purposes of this lecture, though, we will concentrate on thromboemboli. So anything that blocks the blood flow in the pulmonary arterial system. Basically what happens is a DVT, a deep vein thrombosis, develops in the legs or pelvis. The DVT, or blood clot, breaks loose and travels in the bloodstream until it reaches a pulmonary artery on the right side of the heart. This clot eventually becomes stuck or lodged in a small pulmonary artery. Because the clot is larger than the artery, the clot will block the blood flow. No blood can flow past this clot. If a clot is obstructing blood flow to a major part of the lung, it can result in instant death. There are risk factors for developing a pulmonary embolism. Number one is immobility. Immobility is the primary risk factor. Second would be impaired venous flow, blood vessel damage, and altered blood coagulation. The signs and symptoms depend on the size of the clot and the location where it lodges. Small clots may cause no symptoms because they don't block the blood flow. A large embolism presents with signs and symptoms that mimic a myocardial infarction or a heart attack. So the person has abrupt, sudden chest pain, abrupt dyspnea, a cough, tachycardia, tachypnea, diaphoresis, cyanosis, and anxiety. Treatment, prevention is key. Much easier to prevent a pulmonary embolism than it is to cure one. So, TEDs or elastic stockings, pneumatic compression devices, anticoagulants, early ambulation, repositioning, elevating the legs, leg exercises, and range of motion to help prevent a clot. The diagnostic tests for pulmonary embolism include a blood test called a plasma D-dimer level. An elevated level indicates there is a blood clot. Ventilation perfusion scan is going to evaluate the blood flow in the pulmonary circulation. A pulmonary angiogram uses contrast media to evaluate the pulmonary circulation. And chest x-ray and EEG are done to rule out myocardial infarction. Remember, I said that the symptoms mimic the symptoms of myocardial infarction. The treatment is medication, anticoagulation therapy. First of all, we use thrombolytics or fibrolytics, as they're called some parts of your book. These are clot-busting meds, and they're given to dissolve large clots. You don't have to memorize any of the names, but oftentimes they end in the suffix ASE, like streptokinase, urokinase, etc. So those are the thrombolytics, which are the clot busters. Then there's low-dose heparin. Lovenox is a low-dose heparin. That's given subcutaneously to prevent DVT. IV heparin is given to treat an existing embolism. And Coumadin or warfarin is given also to prevent clots. Heparin will be continued initially until the warfarin is effective. That takes about a week. The patient will be on maintenance anticoagulation therapy for 2 to 3 months or longer, depending on the cause of the coagulation problem. Nursing implications with anticoagulants. Bleeding is the primary risk, especially intracranial bleeding. So the nurse monitors for signs and symptoms of bleeding, bleeding gums, nosebleeds, bruising, black tarry stools. It's a good idea to test for occult blood and hematuria. So you want to monitor the lab work closely when somebody's on an anticoagulant. The PT level, the APPT level, both for heparin, the PT and INR for Coumadin, the hemoglobin and hematocrit, and the platelet count. When you're administering anticoagulants, if you're giving sub-Q heparin, you administer it deep sub-Q and rotate the sites on the lower abdomen. When you're giving sub-Q heparin, remember not to massage the area with your alcohol pad and do not aspirate. Always when giving heparin, check the dose with another nurse before you administer it. IV heparin, you want to monitor the infusion rate and the flow and never mix IV heparin with other meds. For Coumadin, which is given PO, it should be given at the same time every day, and foods that are high in vitamin K should be limited. Those are your green leafy vegetables like spinach, asparagus, broccoli. Also things like cauliflower, cabbage, dairy products like milk, cheese, and yogurt. All of that stuff. There's a lot of them. I will put a list in the back of this package. And then the thrombolytics are given IV. You want to be very careful and check the infusion every 15 minutes for the first hour, then every 30 minutes for 2 hours, then hourly while it's going on. While somebody's on thrombolytics, there should be continuous cardiac monitoring and always be checking the neurochecks for the level of consciousness and monitoring for intracranial hemorrhage. Patient teaching, when they're on an anticoagulant, use a soft toothbrush, inform the dentist that you're on anticoagulation therapy, see the dentist regularly. He may or may not recommend flossing, so that would be something you'd want to discuss with your dentist. Know the signs and symptoms of bleeding that you should report to your PCP, such as bruising, bleeding gums, nosebleeds, black tarry stools, or blood in the urine. Avoid meds like aspirin and ibuprofen, which also have an anticoagulant effect, unless advised otherwise by your physician. Have your lab work done regularly. Keep your PCP appointments. Avoid alcohol. If you're on Coumadin, take it at the same time of day, and avoid foods high in vitamin K. Use birth control to prevent pregnancy while on anticoagulants because they can cause birth defects, and always wear or carry a med alert notification. Surgery, an umbrella filter may be inserted into the inferior vena cava through the femoral or jugular vein to trap the emboli, but you don't see that very often. It has been done more in the past, but it did meet with some controversy for a while. So you don't see that procedure done often, only when the clotting is totally unable to be controlled with anticoagulation. The second thing I'm going to talk about in this lecture is pulmonary hypertension, or PH. Pulmonary hypertension is an abnormal elevation in the pulmonary arterial pressure. Normally, the pulmonary blood pressure or the pulmonary arterial pressure is low when you compare it to your systemic blood pressure. For example, and normally your pulmonary arterial pressure should be 25/10. Your systemic blood pressure, normal, would be 110/70. But with PH, or pulmonary hypertension, the pressure rises in the pulmonary arteries. It rises above 45/15, which is very high pressure in the pulmonary arteries. And it goes even higher as the disease progresses. As a result, the inner lining of the pulmonary arteries thicken and hypertrophy. That happens early on with PH. Later, there is destruction of the alveoli, causing increased resistance and higher pressure. The increased pressure puts strain on the right ventricle of the heart, leading to an enlarged heart and possible heart failure. The causes of pulmonary hypertension: sometimes there is no known cause, but usually it is caused by heart disease, lung disease, or a combination of both. The signs and symptoms are dyspnea. That's the most common sign of PH. Initially, there is dyspnea on exertion, and later dyspnea at rest. The person is fatigued, complains of angina, and has syncope or lightheadedness and fainting. Cor pulmonale can develop, or right-sided heart enlargement. With cor pulmonale, the person has a chronic productive cough, worsening dyspnea, wheezing, and the signs and symptoms of right-sided heart failure. You'll see the distended neck veins and peripheral edema, and they also have warm, moist, dusky red skin. The treatment for PH is oxygen, medication, channel blockers, vasodilators, diuretics, anticoagulants. The intake needs to be restricted, and a lung transplant or a heart-lung transplant may be done in the later stages of PH. The nursing care would be exactly the same as that for COPD. Care is mainly supportive. Sadly, pulmonary hypertension has a poor prognosis. Next, I'm going to talk about pulmonary edema. Pulmonary edema is the accumulation of fluid in the interstitial spaces and alveoli of the lungs. The cause of pulmonary edema is often due to heart failure, but that is not always the case, as you will learn when we talk about ARDS and respiratory failure a little later. The signs and symptoms are severe acute dyspnea, shortness of breath, cool, clammy skin, cyanosis, and a productive cough. The cough is usually pink and frothy sputum. You'll hear crackles throughout the lung fields, and the breath sounds become harsher and breathing more labored as the condition worsens. Literally, the patient is drowning from all the fluid in their lungs. Pulmonary edema is a medical emergency that must be treated immediately, or cardiac and respiratory arrest will occur. Keep in mind as we continue with the lecture tonight, pulmonary edema will be a factor in ARDS and respiratory failure. So that's a good segue into the next section, which is adult respiratory distress syndrome, or ARDS. ARDS is a severe acute form of respiratory failure. It is not a primary disease. Again, it is not a primary disease. It is the result of another condition. If not treated, it can lead to respiratory failure and death. ARDS is a non-cardiac severe form of pulmonary edema. With ARDS, the pulmonary edema is not caused by heart failure. There is no cardiac involvement. Causes of ARDS: 1, aspiration. It could be from a near drowning experience or aspirating vomitus, a drug and alcohol overdose, severe smoke inhalation, chest trauma, shock and sepsis, or the complications of H1N1 influenza. There are other conditions that can lead to ARDS. These are just some of the more common causes. And I would also say that in people with severe COVID, adult respiratory distress syndrome definitely is a factor. The pathophysiology of ARDS is, after the causative event, there is a massive unregulated inflammatory response that occurs and damages the lungs. The lung damage happens rapidly, usually within the lung damage happens rapidly, usually within 24 hours of the initial causative event. The alveoli capillary membrane is damaged and blood and plasma cells leak into the interstitial space in alveoli. This causes surfactant to be inactivated. The lack of surfactant causes the lungs to become stiff and non-compliant. The alveoli collapse and it leads to dyspnea and impaired gas exchange. So the patient becomes hypoxic and hypercapnic. The signs and symptoms of ARDS. Remember, the signs and symptoms are going to develop 24 to 48 hours after the initial causative event. So the person will have dyspnea and tachypnea. That's the initial symptom. As the disease progresses, they have rapid, shallow, labored respirations. They become cyanotic. You can see them using their accessory muscles to try to breathe. Respiratory distress is not initially relieved with oxygen administration. Anxiety, restlessness, confusion, agitation, and drowsiness. That's happening because of cerebral anoxia. The brain isn't getting enough oxygen. The person goes into respiratory and metabolic acidosis. They can become severely hypoxic and severely hypercapnic. The diagnosis is going to be based on the arterial blood gases. The arterial oxygen is diminished. It'll be down to 50 to 60 mm's. The arterial CO2 is elevated over 50. And the pH is diminished, indicating the person is in acidosis. A chest x-ray will show no evidence of heart failure, and diffuse infiltrates with a whiteout pattern throughout the lung where the lung tissue is collapsing. Ventilation perfusion scans evaluate the alveoli, ventilation, and the gas exchange. So that is ARDS. Respiratory failure, which is very closely related to ARDS. Basically, with respiratory failure, the lungs are unable to oxygenate the blood and cannot remove carbon dioxide, even when the body is at rest. Respiratory failure. Basically, the lungs are unable to oxygenate the blood and cannot remove carbon dioxide successfully, even when the body's at rest. Respiratory failure, like ARDS, is not a disease. Instead, respiratory failure is the result of another disorder. COPD is the most common cause of respiratory failure. Other causes include lung disease, trauma, neuromuscular disorders, and heart disease. So, respiratory failure is the result of severe respiratory function impairment caused by an underlying condition. It is not a disease, just as with ARDS. What you will see is blood oxygen is diminished to probably 50 to 60, and blood carbon dioxide is elevated because the lungs cannot exhale to eliminate it. So the carbon dioxide will be over 50. The signs and symptoms reflect the hypoxemia and the hypercapnia. So hypoxemia, the patient is going to have dyspnea, tachypnea, cyanosis, restless, anxious, confused, tachycardia, dysrhythmias, hypertension, and metabolic acidosis. Hypercapnia symptoms are dyspnea, respiratory depression, headache, drowsiness, coma, tachycardia, hypertension, heart failure, and respiratory acidosis. The treatment of ARDS and respiratory failure. Successful treatment is dependent on treating and eliminating the underlying cause. The prognosis also depends on the cause. For example, if the respiratory distress or the failure was due to a drug overdose, once the drug is out of the person's system, the respiratory distress failure will probably resolve quickly and completely. However, if the underlying cause is something like COPD, the disorder will run a longer course with less favorable results. So number one in treatment, remove the underlying cause. Oxygen therapy. If the cause is COPD, the patient will receive 1 to 3 liters of oxygen via nasal cannula. Other patients receive oxygen at higher concentrations via humidified face mask. High concentration of oxygen is only used short term because it can lead to oxygen toxicity, which is going to diminish the lung compliance. CPAP may be used instead of a traditional oxygen delivery system because it improves the alveolar ventilation and allows a lower oxygen concentration. So it's going to reduce the chances of oxygen toxicity. Signs of oxygen toxicity would be more frequent coughing. Patient complains of throat irritation, chest pain, more dyspnea, muscle twitching, especially face twitching, face and arm twitching, dizziness, blurred vision, confusion, and seizures. All of that are signs of oxygen toxicity. So, maybe the oxygen therapy isn't working at this point. The person may need to be put on mechanical ventilation. Mechanical ventilation The patient may require mechanical ventilation. They'll be intubated with an endotracheal tube, and then that will be connected to the ventilator. Positive and expiratory pressure ventilators are used for ARDS and respiratory failure. These ventilators work by pushing the air into the lungs to increase the lung volume and reduce oxygen demand and the workload of breathing. A tracheostomy might be needed if mechanical ventilation is needed for more than 3 to 4 weeks. Medications include bronchodilators, antibiotics if there's an infection, corticosteroids to reduce edema and inflammation, and surfactant therapy. Surfactant therapy would only be for patients with ARDS. Other forms of respiratory failure do not destroy their surfactant. The clients on mechanical ventilation may need these additional meds: anti-anxiety and sedating meds, and analgesics like IV morphine. The person is very, very anxious and may be having a lot of pain when they're on the mechanical ventilator, and so these meds are used then. You would not want to use these meds if the person was not on a mechanical ventilator, because anti-anxiety meds, sedating meds, and analgesics such as morphine reduce the respiratory drive, and that will facilitate respiratory failure. So anybody that's able to breathe should not receive anti-anxiety, sedating, or analgesic meds like morphine. If they are on a ventilator, these meds help reduce the respiratory drive so that the machine can take over and make it easier. The nursing care: impaired ventilation or ineffective airway clearance. Assess the vital signs and respiratory status every 15 minutes and assess the level of consciousness at the same time. Monitor the arterial blood gases and O2. Administer oxygen, monitor closely. Monitor for signs and symptoms of oxygen toxicity. Again, those would be blurred vision, dizziness, muscle twitching of the hands and face, and seizures. The person should be in the Fowler's position. That increases ventilation and reduces the workload of breathing. Encourage rest to reduce oxygen and energy demands. Avoid sedatives and respiratory depressant drugs unless the patient is on a ventilator, because these meds can depress respiratory drive. Assess the lung sounds and respiratory statuses. Crackles, rales, persistent coughing, restlessness, anxiety, frequently setting off vent alarms. All of these things may be signals that the person has an ineffective airway clearance, and they may need and probably do need to be suctioned. Obtain sputum specs for CNS if the sputum appears purulent to rule out infection, and perform postural drainage, percussion, and vibration to loosen secretions and move to larger airways. Maintain the fluid intake, monitor intake and output, and daily weights. You want to prevent the complications of immobility with frequent position changes. Keep the skin and linen clean, dry, and wrinkle-free, and perform passive range of motion exercises at least once a shift. Administer meds as ordered. For anxiety, stay with the person as much as possible. Provide reassurance, explain monitors, procedures, machines. It's a pretty scary thing when you're on a vent and you can't breathe. Provide alternative means of communicating. Anyone on a vent that's intubated cannot talk, so work out ahead of time using a slate or a picture board. And then always reassure the patient that you know how frightening it is not to be able to speak. Encourage the family members to visit frequently and to participate in the patient care as much as possible. Provide distractions like radio, TV, their personal computer, and help divert their attention from the tubes, machines, alarms. If the patient is on mechanical ventilation, administer anti-anxiety and sedating meds as ordered. So next, and to end the lecture too, I want to talk about endotracheal intubation and mechanical ventilation. First, you want to prepare for the procedure. Obtain a sterile intubation tray with sterile endotracheal tube, ETT, and a laryngoscope. Have sterile gloves and sterile normal salines, and have your endotracheal suction set up ahead of time. The ETT tube is going to extend from the mouth or nose into the trachea. Explain the procedure to the patient. Reassure them that this is temporary to make it easier to breathe and allow time for them to rest. Explain to the patient that they're not going to be able to eat or drink while intubated and receive enteral nutrition, like a tube feeding. Also explain the tube feeding and what's involved. And explain to the patient that they're not going to be able to talk while they're intubated, and establish those alternate ways of communication. Pad and paper, magic slate, computer, picture board. Explaining things to people helps to curtail their anxiety. And people that are intubated or have a mechanical vent or both are so anxious already, everything you can do will help to relieve their anxiety. During the procedure, an endotracheal tube is passed from the mouth or nose into the trachea. Usually there's a foam or air-filled cuff just above the end of the tube where it enters the trachea. This cuff is going to prevent air from escaping back into the upper airway. After the tube is passed, an ET holder, which goes around their head and secures it, will help secure it in place. The tube placement is marked in relation to the nose or mouth. Stay with the person during the procedure. After the ETT is in place, notify respiratory therapy to set up the vent, and request a portable chest x-ray to verify the position of the tube.
Hi, I'm Andy Bourgeois, an emergency physician, and I'm going to review how to intubate a patient with known or suspected COVID-19. We want to minimize exposure to staff, so ideally there will only be 3 people in the room: the physician, a respiratory therapist, and a nurse to administer medications. Intubation should occur in a negative pressure room. First, we need to make sure our equipment is ready. A viral filter is inserted between the bag and mask. Then we need to make sure we have an end-tidal CO2 detector, Ballard, ET tube with syringe and stylet in place, ET tube securing device, and video laryngoscope. Video laryngoscopy is preferred over direct laryngoscopy for 2 reasons. The provider is farther from the patient, and the time to ET tube placement is likely faster. Ideally, the patient should be pre-oxygenated and denitrogenated by applying oxygen via high-flow nasal cannula or with CPAP. The nurse can then administer sedation and paralytics. The ET tube should be passed as quickly as possible, and ideally just as the patient becomes apneic, so that we don't have to bag while we're manually trying to maintain a good seal. The ET tube cuff should immediately be inflated. Next, the Ballard is attached, followed by the viral filter, end-tidal CO2 detector, and then the bag. The patient can then be bagged until a ventilator is ready and the circuit can be disconnected after the viral filter. The circuit should never be broken before the viral filter, and these 3 joints should be taped to prevent accidental disconnection.
The nursing care, you want to monitor the endotracheal tube in the vent very closely, assess for air leakages, changing in breathing sounds, respiratory rate and character, assess the tube placement, and notify the supervisor of any changes. Suction the ETT-PRN using sterile technique.
Nothing is more alarming than when the ability to breathe freely is compromised. When an individual is unable to naturally mobilize and expel respiratory secretions on their own, it's an indicator that their ability to breathe has become impaired. Treatment to alleviate this impairment and remove the accumulated secretions can be found through the assistance of healthcare professionals trained in airway management. An accumulated airway not only hinders a person's ability to breathe, but can complicate normal oxygenation and cause hypoxemia. We'll begin by looking closely at the human airway.
I did put in the back of the packet endotracheal suctioning procedure and also tracheostomy suctioning procedure, just to review. Provide frequent mouth care. Move the oral endotracheal tube to the opposite side of the mouth every shift. Assess the mouth and mucous membranes and monitor for irritation and redness. If a patient is on a mechanical vent for more than 3 or 4 weeks, a tracheostomy may be done. So refer to the suctioning for a tracheostomy as well. Complications of intubation. Anytime anything enters your system, you're at an increased risk for infection. Pressure necrosis of the nose, lips, or trachea may occur. There's a thing called ventilation-associated pneumonia, pneumothorax, emphysema, and a decreased cardiac output. Complications can be prevented with proper management and care of the endotracheal tube and vent. And when an endotracheal tube is removed, the patient will be put on humidified oxygen. It is common for the patient to complain of hoarseness and sore throat when the tube is removed. Food and fluids are introduced slowly. The nurse needs to assess the patient closely to make sure there's no aspiration and for respiratory distress. The signs and symptoms of respiratory distress after intubation would be nasal flaring, dyspnea, wheezing, anxiety, and decreased oxygen sats. If respiratory distress occurs, reintubation will probably be necessary. Then finally, weaning the patient from a mechanical vent. If a patient has been on a mechanical vent short term, they may be taken off the vent and extubated rapidly. If mechanical ventilation has been prolonged, a gradual weaning process takes place where they'll be on and off of the vent periodically, and then the time they're off of it will be increased slowly. Nursing care when weaning, monitor very closely. Watch the vital signs, the respiratory rate, assess for dyspnea, oxygen saturation, arterial blood gases. If the oxygen saturation or the PaO2 falls below specified parameters, mechanical ventilation will probably be reintroduced. And that is the conclusion of this section of the lower respiratory tract. I know it's a lot of material to digest, It really is difficult and it's very complicated, but I'll try to narrow it down and we'll have and during my office hours, we can talk about it. Don't become too stressed out about it mostly. Pay attention to my lecture when you're studying. Read the chapters though. You don't have to memorize everything in them, but just read them for general knowledge, and it will help you to understand the lecture better.